Welcome to the national webinar on treatment and complications of COVID-19. Let us begin the session by invoking the blessings of God Almighty. I invite Ms. Archana for the prayer song.
They shall be reviving only they blessing we need. But for the shower,
Thank you. Now invite Mrs. Nivia Mariam Paul, HOD, Department of Microbiology, for the welcome speech.
Good morning, everyone. As we all know that day by day, the effect of COVID-19 seems to reach a new, strange and tragic situation. More than 1 million infected people have lost their lives. Now, everyone in the healthcare sector is trying really hard to control this pandemic. Their action really motivates us to do our responsibilities in this mission. In this scenario, it is necessary to know more about the virus, its proper treatment methods, and its complications. The Department of Microbiology, in association with the Departments of Biochemistry and Biotechnology, is privileged to organize this webinar on treatment and complications of COVID-19, which may help us to prepare, respond, and recover this pandemic. So, first of all, on behalf of our Secretary, Dr. Vinny Varghese, and our Principal, Dr. Shandy A. Avida, I would like to welcome all the participants to this prestigious webinar. On behalf of Marathnicius College, I feel honored to welcome our esteemed resource person, Dr. Joe Joseph, as our chief presenter in this webinar. Dr. Joe is an associate professor in the Department of Medicine at Government Medical College, Ernakulam. He is one of the team leaders specialized in COVID-19 treatments since 8 months. That is, from the beginning when hospitals in Kerala started treating COVID-19 patients. Moreover, he is a passionate teacher and has several publications in both national and international journals. We are sure that Dr. Joe is the right person to enlighten us with his experience and expertise in treating COVID-19 patients. I once again welcome Dr. Joe to this webinar. We have participants from all over India, like students, teachers, technicians, scientists, people from health sectors, and other various departments. Also, we have international participants from countries like Australia, Kuwait, Pakistan, Egypt, UAE, Nigeria, and China. We welcome you all to this session. I'm sure all the participants will be enriched with knowledge by this event. Once again, welcome all and thanks for joining. Thank you.
So good morning, everybody. Let me thank my college for organizing this seminar, especially the departments of microbiology, biotechnology, and biochemistry. So thank you again for having given me an opportunity to speak in this webinar. So let me start with the slides. So, coming to COVID-19, this is COVID is coronavirus induced disease. So which virus are we talking about? It's the SARS-CoV-2 virus. SARS-CoV is severe acute respiratory syndrome coronavirus 2. So there was an earlier virus, SARS-CoV, and that was in 2003 with the similar symptoms and clinical features, and this was less contagious and was contained early. Now this COVID-19 started in a market in Wuhan 2019 and spread to other parts of the world and was declared a pandemic on 11th March 2020 by the WHO. So the coronavirus, they have been for some time causing respiratory problems in the world. So these are some of the coronaviruses: SARS-CoV 2003 and the MERS 2012, Middle East Respiratory Syndrome, and the milder respiratory coronavirus HCoV, and now we have the SARS-CoV-2, which has produced the COVID-19 pandemic. So coming to epidemiology, bats are the most common reservoir for coronavirus and may be the source of COVID-19. Pangolins are said to be the intermediate host. Median incubation period is 5 days, and transmission is via droplets from coughing, sneezing, or direct contact from fecal and from fecal transmission. So mortality rates are higher in men, probably due to lifestyle difference rather than chromosomes. Smoking, especially, more prevalent in women, men, and lung diseases. These are the major cause of morbidity and mortality in COVID-19. So that is maybe one reason why mortality rates are higher in men. Now, susceptibility, obesity, hypertension, CAD, and chronic lung disease. These are factors which affect morbidity and mortality in COVID-19. And one factor which I forgot to mention here, that is age. Age is the most important factor, which is predisposer for mortality in COVID-19. So in Sweden, in a country of 1 crore population, there are more than 5,500 deaths. And 90% of these deaths occurred in people aged 69 or above. That is, age is a major risk factor for morbidity and mortality in COVID-19. So in our hospital also, most of the patients who die, they are older people. Younger people have much better survival rates. And in younger people, we have noticed that in our hospital that obesity is a major risk factor. Most of the younger patients in our ICU, they were obese and they had severe disease. Hypertension, coronary artery disease, and chronic lung disease, etc. are other risk factors for severe COVID-19 disease. So coming to blood groups, O group, people with O group, people who are O group, and they are less likely to contact COVID-19, and Rh negative people are less likely, and it is higher among non-O, that's A, AB, and B, and Rh positive patients. And risk of death high among A, B, and B, and low among A and Rh negative people. Now, just something about herd immunity. So, when sufficient number of people in a community are infected, then the chain of infection is broken and the rest of the population is protected. That is, everybody in the community, suppose there are 1 crore people in a particular community, not everybody has to be infected before the infection drops. That is the herd immunity. So infections like COVID-19 spread from person to person as in a chain. That's why we always emphasize break the chain. So that is how it moves from person to person as in a chain. And once sufficient proportion of the population is infected, the virus can't spread because it keeps encountering people who are already immune. And why they are immune? They may be immune because they have been already infected or they have been vaccinated. So this breaks the chain because the virus encounters people who are immune and protects the rest of the population. So it can occur either through vaccination or infection. The percentage of people who need to be infected for achieving herd immunity varies from disease to disease. So this percentage, that is called the herd immunity threshold. Herd immunity threshold is dependent on the basic reproductive number. So there's two factors. One is the basic reproductive number, or R0. R0 is the number of people who can contact the disease from an infected person. For example, somebody is COVID-19 positive, he can infect 2.8 people. That is, the R0 of COVID-19 is 2.8. While the R0 of measles is around 15. So if a child has measles, he can give that infection to 15 other people. So that's the concept of R0. So higher the R0, higher the herd immunity threshold. For example, measles, which has an R0 of 15, the herd immunity threshold of is 95%. That is, if 95% of the population gets infected, then the 5% what is left is automatically protected from measles. So R0 for COVID-19 is 2.8, and the herd immunity threshold is calculated by the formula 1 minus 1 by R0. That is, the herd immunity threshold for COVID-19 is around 64%. So that is 2/3 of the population has to be infected before or immunized through vaccines before we get herd immunity. For a state like Kerala, population of 3 crores, once 2 crore people are either infected or vaccinated, then the rest, the 1 crore, they are supposed to automatically get immunity from the disease through herd immunity. Now, coming to pathogenicity, the most affected organ is the lung, and the major cause of mortality is pneumonia and acute respiratory distress syndromes. Other organs like the heart, kidney, brain, liver, gastrointestinal tract also can be affected, thus causing myocardial infarction, that's a heart attack, or kidney failure, renal failure, or strokes in the brain. So other organs can also be affected, but the lung is the organ which is most affected and the most probable cause of death in mortality in COVID-19. So the SARS-CoV-2 enters the body usually through the respiratory tract or gastrointestinal tract. It enters the cells via spike glycoprotein, which binds to the angiotensin converting enzyme 2 receptors. And once it binds to the cells, the transmembrane serum protease enables fusion of cell membrane of host and viral envelope. So such cells which are having high quantities of this angiotensin converting enzyme 2 receptors and transmembrane serum protease, these are much more vulnerable to infection by the SARS-CoV-2 virus. So type 2 pneumocytes in lung and epithelial cells in upper esophagus have high concentration of ACE2 receptors. Hence, these cells are highly vulnerable to SARS-CoV-2 virus infection. Now, once inside the cell, the virus replicates and destroys the cell. Now, coming to type 2 pneumocytes, which are the culprits in lung lesions, major culprits, other cells also can be involved. They are used in surfactant synthesis. Damage to these cells not only destroy the cells, but they can also result in an inappropriate immune response, resulting in excessive cytokine synthesis and activation of inflammatory cell release. That is, once the virus infects the cell, they send some signals which causes release of inflammatory particles like TNF alpha, interleukins, GM-CSF, interferon, etc. So these molecules are highly toxic and they damage various organs, and this is called the cytokine storm. And once the cytokine storm occurs, there can be critical damage in organs like the liver, kidney, heart, etc. Also, the virus can sometimes activate the procoagulant factors, leading to thrombus. That is, there is lot of clots in the arteries and veins. And if suppose an artery of the heart supplying the brain is clotted, or there is a clot inside that vessel, then you can have a stroke. So there are three methods by which this virus destroys the organs in the body. One is it can directly kill cells. Other is it can lead to an inappropriate immune response, causing a cytokine storm and killing and damaging many organs. Thirdly, it can activate the coagulation pathway and causing clots in multiple vessels and causing damage to multiple organs. So these are the clinical features. I think everybody will be knowing about that. The most common symptoms of, let me say that most patients are asymptomatic or have only mild symptoms. That is maybe more than 80% to 90%. They don't have any symptoms. We had a family from Italy that was in March, and there was the parents, one child and a baby. So the baby came with fever. Since the family had come from Italy, the baby was tested for COVID-19 with RT-PCR. The baby tested positive, but the mother, father, and the other child, they remained totally asymptomatic, very healthy, no symptoms, no fever, no cough, no sneezing. So many of the people around you who are absolutely normal may be having the infection. These are asymptomatic carriers, but the danger is they can spread the disease. That is why the government is insisting on masks and sanitizers, social distancing, and all these things, because even a person who is absolutely asymptomatic can be carrier and infect you with COVID-19. So these are the symptoms: fever, dry cough, fatigue. Other symptoms are less common, and loss of taste or smell, nasal congestion, red eye, sore throat, muscle or joint pain, different types of skin rash, nausea, vomiting, diarrhea, chills, or dizziness. So severe symptoms or red flag signs: shortness of breath, loss of appetite, confusion, persistent chest pain, high temperatures, reduced consciousness, anxiety, depression. These are some of the severe symptoms of COVID-19. There are also very severe, rare complications like strokes. They can again heart attacks, in infection of the heart. These are also sometimes seen in COVID-19 infections. So coming to the investigations, now testing for COVID-19, I think already a webinar has been done on this by the MA College, so I won't go into that. Or everybody knows, I think, antigen, RT-PCR, and CRISPR. These are the things used for testing of COVID-19. Now coming to clinical investigations, I won't go into every investigation. Now the basic investigation is a blood count. Blood count is you take the blood and look for how many neutrophils, how many lymphocytes, how many basophils and eosinophils are there. In a normal patient without any disease, there are around 60 to 65 neutrophils and 30 to 35 lymphocytes. So that's the ratio, around 2:1. That's a normal ratio of neutrophils to lymphocytes in a normal patient. A person having a viral infection usually has increased lymphocytes. But strangely in COVID-19, what happens is the lymphocyte count drops. So a patient will be having, say, a count of 10,000, of which 80% may be neutrophils. Lymphocytes are only 10%, and that is the neutrophil lymphocyte ratio increases in COVID-19. And the neutrophil lymphocyte ratio more than 3.8 is an indicator of severe COVID. So somebody comes with a say a neutrophil of 85% and 10% lymphocytes. Lymphocytes are low. That patient is likely to go in for complications. Next slide. So renal function test and liver function test, this may be deranged, creatinine may be raised, bilirubin may be raised, liver enzymes may be raised. Now we have in pathology we have said that virus can kill the cell, or there may be an inappropriate systemic inflammatory response. So coming to inappropriate systemic inflammatory response, the indicators are high raised serum LDH, raised serum ferritin, and raised C-reactive protein, otherwise CRP. These are the indications for evidence of inappropriate systemic inflammatory response, which can lead to a cytokine storm and multiple organ dysfunction. Now coming to serum D-dimer, this is an indicator of raised coagulation, hypercoagulability. So once you see that the D-dimer is very much raised, you should think that the patient may go in for a clot and block in various organs. So these 4 tests we routinely do for all patients, and interleukin 6 levels that also we do. And if you are planning for some monoclonal antibodies also. Now coming to X-ray, the features are bilateral peripheral opacities, ground glass opacities, and crazy pavement sign. So this is an X-ray. The first X-ray, that's a normal X-ray. It's a normal X-ray. I hope you can see. See these black things, you can see on either side, left and right, there is a black. That black is air. You can see the white. You can see the pointer. This is the lung. This is the right lung. And this is the left lung. So it's full of air. This is full of air. This is the heart. This white part is the heart. You see the left lung and the right lung. And now you see a bacterial pneumonia. Here you can see that one lung is affected. Here you can see the right lung is affected. And you can see the white patch. That white patch is the pneumonia. Only one lung is affected. And this is a typical chest X-ray in a bacterial pneumonia. Now you come to COVID-19, you can see that both lungs are affected. There is bilateral involvement of lungs, especially in the peripheral part and the lower part. So this is a typical X-ray of COVID-19. Bilateral lesions with ground glass opacities, lesions more on the periphery and on the lower parts. Bilateral lesions you can see in other viral pneumonias also, but ground glass opacities and crazy pavement signs, etc. are more common in COVID-19 infection. Now coming to the CT scan, these are the things you get: ground glass opacities, reticular opacities, consolidations, crazy pavement sign, pleural thickening. Pleural effusion rare. Pleural effusion is rare, but still can be seen very rarely. Now coming to CT scan, it is said that CT scan has more specificity than RT-PCR. That is, if you see a patient who has been in close contact with the COVID-19 patient, he comes with fever, cough, breathlessness, and you are strongly suspecting COVID-19, you do an RT-PCR, RT-PCR is negative. Then you take the patient for a CT scan of the chest, and the chest CT comes, all the typical findings are there, these ground glass opacities, consolidations, crazy pavement sign, etc. are there. Then you can be sure, even though the RT-PCR is negative, this patient is at COVID-19 positive. So CT scans, slightly more specific for COVID-19 than RT-PCR. So coming to treatment, COVID cases can be classified into asymptomatic phase, viremic phase, immunologic phase, recovery phase, and post-COVID phase. Patients in the viremic and immunologic phase can sometimes become critically ill. So in the start of treatment, so let us go to the viremic phase. Here, the viremic phase, you use antiviral drugs. Next slide. So these are the antiviral drugs, remdesivir, favipiravir, and remdesivir is developed. These are all repurposed drugs because these have been used for other diseases, and now because we don't have any other medication to be used, so we are giving these drugs. Remdesivir has been used for Ebola. It has been developed by the Gilead Sciences and has to be found effective in Ebola. And HCQS is being widely used in rheumatoid disorders. Favipiravir again, favipiravir, lopinavir, ritonavir in HIV, AIDS, you use these drugs, and azithromycin is an antibiotic. And coming to remdesivir, so these are all repurposed drugs. Drugs which have been developed for other diseases, now being used for COVID on an experimental basis. So coming to remdesivir, developed for Ebola, trials like ACT Simple showed that remdesivir has a significant role in reducing time of recovery, but no mortality benefit. That is, these studies have shown there is no mortality benefit, but patient recovers fast. It's a nucleoside analog prodrug which inhibits viral RNA synthesis, viral RNA polymerase. It is given for 5-day course. It's a very expensive medication. A 5-day course can cost around 25,000 rupees. And sometimes liver enzymes can be raised, then you have to stop the medication. Liver enzymes and renal function tests, they have to be monitored every day to see that they are not rising. If they are rising, then you stop the drug, remdesivir. Now, significant elevation of liver enzymes, renal failure, and pregnancy are contraindications. Now, you should know that these drugs can only be given with informed consent. And now, lately, very recently, WHO has come with a study saying that remdesivir may not be of much use. But immediately after the WHO said this, the FDA, that's the American drug agency, they have given approval for remdesivir. And not only that, they have given shots of remdesivir to their president, Donald Trump. So we are all confused whether to use it or not. When the WHO says it is not of much use, but the US government is actively promoting, and they have used it even in their president. Favipiravir, it is useful only in very mild disease, and it has some side effects, same as remdesivir, renal failure, liver failure, and sometimes causes QT prolongation. So HCQS, the solidarity trial, and this is a drug used for rheumatoid disorders, and sometimes some variant of it is used in malaria also. Found to be very safe drug. People are commonly using it in rheumatoid disorders, and although the solidarity trial and the recovery trial showed that HCQS was not of much benefit, and we are still using that in our state. It is recommended. It does not do any harm, and it has some antiviral properties. So another drug which is used against the virus is this convalescent plasma. Convalescent plasma. These persons who are infected with COVID-19, they develop antibodies to the virus, and these antibodies remain in their body for a long time. So once these people have recovered, you can take their plasma and give it to infected people, and hope that these antibodies will kill the virus. So this is 1 unit of 300 ml plasma, convalescent plasma, can be taken from a person who has been COVID positive and is now COVID negative for 14 days. If there is, so you check, once you give convalescent plasma, you check for neutralizing antibodies. They are not present. You can give one more 300 ml unit of convalescent plasma. So one thing is for this convalescent plasma and antiviral drugs like remdesivir, they have to be given very early in the disease, that is in the viremic phase. If they are given later, these are not of much use, because once the viremic phase is over, then antiviral drugs don't act. And once 1 week has passed, around 8 days, the person who is infected, he himself starts developing antibodies. So there is no point in giving convalescent plasma to a person who has come late or is in the late stages of the disease. So some trials about convalescent plasma, Congovit trial that is done in Holland, it was terminated prematurely because it was found not to be of much benefit. Many of the patients who were given in that trial, it was seen that many of the patients who were given plasma had already had neutralizing antibodies. The Placid trial that was done in India also showed no mortality benefit. And now it seems the ICMR is proposing to discontinue plasma therapy because of this Placid trial and the results shown that. So convalescent plasma is a relatively safe therapeutic option. You don't see many side effects. Since convalescent plasma is difficult to obtain and non-specific, monoclonal antibodies against the virus were produced in vitro. So here antibodies which were produced by the body, they were produced in vitro, and that is done in the beginning by a company called Regeneron. They produced antibodies against the virus, which is similar to the antibodies produced in the human body. And in the UK, there was some trial using the RECH-CoV-2 antibody. This undergoing, it has a good safety profile, and some other phase 1 study or again of another antibody that is also going on. And it must be remembered that US President Donald Trump was given a concussion of these antibodies when he was COVID positive. So I think that also shows that there is some promise in this monoclonal antibodies against the virus. These monoclonal antibodies are against the virus. So coming to treatment against the virus, there is antiviral drugs, not of much use. Remdesivir is only has some effect, it seems, apparently. And convalescent plasma, again, not proven. Now this in vitro antibodies, like the RECH-CoV-2 antibody developed by Regeneron, they may show some promise, and further studies need to be done about that. So coming to we said virus kills a cell, and nextly the virus sets off an immune reaction which can cause damage to multiple organs. So drugs against this immune reaction. So pro-inflammatory cytokine levels are elevated in COVID-19 infections. Studies conducted in China, including elevated ferritin and IL-6 were predictors of mortality, and suggest that the hyperinflammation is contributing to mortality. Now, steroids, dexamethasone, methylprednisolone, these are some of the steroids, and the analysis of 7 international clinical trials show that corticosteroids decrease mortality to by 1/3 in ventilated patients and by 1/5 in patients requiring oxygen. So this is one drug which has consistently proven effective. It is not an antiviral drug. It does not kill the virus, but it suppresses the hyperinflammatory response, which is caused by COVID-19 virus. And this drug is being widely used, very useful, and it is not useful in the early part of the disease, but as the viremic phase is over and the patient goes into the inflammatory phase, this drug is very useful, and probably the only drug which has so far been accepted by all bodies. And WHO is recommending that it not be used in non-severe COVID patients. So monoclonal antibodies, these are again repurposed drugs. We have mavimab, tocilizumab, itazumab. Mavimab and tocilizumab, they are used in rheumatoid arthritis, while itolizumab has been used in psoriasis. So that when the patient goes for a severe immune response, you can try these drugs. Most of them are not found to be very effective in any studies. Now here we use tocilizumab in our state, and in the country we use tocilizumab and it is an humanized monoclonal antibody against IL-6. And some studies have shown it decreases the duration of hospital stay, while some studies not of much benefit. So when the patient comes, you see that the ferritin is increased and the LDH is increased, the C-reactive protein is very much increased, then you know that the patient is going in for cytokine storm. So you try steroids on such patients. You try steroids, these are the first line and very proven drugs for such patients. And with steroids, the patient is not improving, patient is deteriorating, going in for multi-organ damage. Then you can do see an IL-6 levels. And if IL-6 is quite high, then you can consider tocilizumab. We are using tocilizumab. I don't know how effective that is. Very expensive, 40 to 50,000. So it can. The problem is it can activate other infections in your body. So you have to be very watchful for infections like tuberculosis popping up. Tocilizumab, it is developed by Biocon. It's used for acute psoriasis. So these are monoclonal antibodies. Earlier we talked about monoclonal antibodies against the virus. These are monoclonal antibodies against the immune particles. Mavimab, tocilizumab, and tocilizumab. So coming to you, I told you earlier that there are multiple clots formed in the body due to the activation of the coagulation pathway. So once you see that the D dimer is very much raised, then you can start anticoagulants so that there are no clots. Anticoagulants we use are heparin. There is a plain heparin and there is a low molecular weight heparin, and there is apixaban, which is an oral anticoagulant. Apixaban we give only once a patient when the patient is being discharged. Otherwise, we prefer heparin, plain heparin, and low molecular weight heparin. Now, one of the most important parts of therapy, this is the oxygen therapy and respiratory support. So mainly in our ICUs, we monitor the what is called the PEA set. You can what in layman's terms, I mean, like you can monitor the pulse oximeter. You can use the pulse oximeter to monitor saturation. Important thing is to keep the patient on the saturation above 93%. And in a stepped-up manner, oxygen mask, high-flow nasal cannula, non-invasive ventilation, and mechanical ventilation are used to maintain oxygen saturation. So suppose a patient is COVID positive, he has a lung infection, and he's on room air. Then his saturation drops below 93%. Then you use an oxygen mask, which can supply oxygen at the rate of 5 to 10 liters per minute. You put the patient in oxygen mask, still his oxygenation is not improving. It remains 91%. Then you use a high flow nasal cannula, which delivers oxygen up to 60 liters per minute. So again, you watch the patient, he is not improving. Then you may put the patient on non-invasive ventilation. In non-invasive ventilation, you put the mask and forcibly you blow air into the patient's lungs. And some of these non-invasive ventilation, sometimes they can be removed so that the patient can take food. It can be used intermittently also. This non-invasive ventilation can be used. And even if the patient is not improving with even that, you can put in a tube and mechanically ventilate the patient. If you put in a tube, the patient has to be sedated and sometimes paralyzed also. So this is stepped up. This is very important, oxygen therapy, along with steroids and heparin and prone positioning, very important for the patient. So you go over in a stepped up mask, 5 liters nasal mask, then you go in for high flow nasal cannula, 60 liters, non-invasive ventilation, and finally, there is no other way, you go in for mechanical ventilation. So this is very important, prone positioning. If somebody is having COVID-19 pneumonia, this is the position you should lie in. So the mechanisms of it is proven to be useful in some studies have shown that it is proven to be useful, and it is widely adopted. Most hospitals are using this strategy, because you can see once the patient lies down like this, the lungs in his back part of his body, they start working, and the patient's chest wall elastance increases, and there is improved tidal volume and decreasing alveolar shunt. So this is the position a patient should be in once he is having COVID pneumonia. So ECMO is extracorporeal membrane oxygenation, not widely available because it is very expensive. Some of the private hospitals are having this machine. Once the lung stops or finds it difficult to work, then you can use an ECMO machine. And so machines used to do the work of a patient's heart or lung or both when these organs are damaged. So if you say you have a heart problem and lung problem, you can use ECMO machines, but it does not cure the illness. It only gives time for the body to heal. While the work of heart and lung is being done by the machine, it gives time so that the lungs and lung injury and heart injury, they can recover, and the body can take over from the ECMO machine. So initially, there was a heart-lung machine used in cardiac surgeries for a short period. Now, ECMO machines are similar to heart-lung machines, only they are more sophisticated and they can be used for longer periods of time. Now, one comparison is when the kidney fails, you use dialysis. You use a dialysis machine. When the heart or lung fails and you want to maintain the patient, then you can use a ECMO machine or a heart-lung machine. So this is the ECMO machine. You can take blood from the patient's vein, and it goes to the machine where there is some heating and some oxygen exchange takes place as in the lung. Then it is pumped back into the body through the arteries. The basic thing is you take the venous blood out, you purify it, you heat it, and you put it back into the person's body. You can put it back either through the artery or through the vein. So ECMO is found to be effective in COVID. Some patients with COVID-19, patients with severe lung disease, there's something called a ELSO registry. They have done some study and found that ECMO can be useful in patients with very severe COVID disease. Now, the drawback of ECMO is that it is very expensive and can cost from 50,000 to 1 lakh per day, because you have to change the components of the ECMO machine quite often, especially the filters, and they are very expensive. And that is the major drawback of ECMO machine. And also, you cannot indefinitely continue on ECMO machine. You can only give by time with these ECMO machines. Now, vitamins and zinc, these are routinely given. Vitamin C elevates the inflammation status by reducing ILC, CRP, etc. And it may be beneficial on thrombotic things also. So vitamin D, we are routinely giving 60,000 units daily for 3 days or weekly. It has been found that mortality is higher in COVID-19 patients with low vitamin D levels. And zinc enhances antiviral immunity. These are all the supplements you give. No harm in giving all these drugs. At least they may be beneficial. So one of the most important parts of COVID-19 care, that's nursing care. I'm not going into the details, but very important. This has to be done very meticulously. And so many times the patient are dependent on nursing care. So coming to just summarizing the treatment, antiviral drugs are there. These are repurposed drugs. Remdesivir is the only one which is found to be a little bit effective. And convalescent plasma, because you want the antibodies in a person who is recovered from COVID-19 not found to be useful. In vitro monoclonal antibodies against viral infections, they are being developed, may be useful. That's about the antiviral drugs. Immunomodulators, steroids, definitely useful. Used at the right time and the right dose, steroids are very useful. And other immunomodulators like tocilizumab, and they are of doubtful use. And coming to the anticoagulants, definitely useful. Heparin, especially in patients with high D-dimer values. So that is a treatment. And nursing care, very important. Oxygen therapy, very important. And respiratory support, very important. And you can give these vitamins and other supportive stuff. But you should know that most of these drugs are repurposed, are of not much use. So the best way to avoid COVID mortality is not to contact it. The government has issued guidelines. These should be strictly followed. 3-layer mask should be used. Social distancing should be followed. And don't go out of your house unless it is necessary. And all the things, sanitization, constant sanitation, hand washing, all these things. Whatever the government has recommended, you should go through this because this is a new disease. Not many drugs, not many treatment effective against. You can see that the mortality is there. Even in the most advanced countries, even in places like Sweden, where they have the most advanced facilities, there are many deaths. And best way to prevent this is to stay away from the disease. Now coming to complications of critically ill COVID patients, this is ARDS, that is acute respiratory distress syndrome. Thrombotic complications, we have mentioned that cardiac injury can occur. Other secondary bacterial infections are rare but can occur. Acute kidney injury is relatively common. And neurological complications, sometimes you can see that the patient becomes confused, drowsy. This is called COVID encephalopathy. Sometimes the patient may develop strokes. So the pancreatic and multi-organ involvement. Sepsis is not very common but can occur. So coming to vaccines, vaccines are probably the most promising advanced what we are looking for in COVID-19 treatment. 2 vaccines currently used in Russia. This is Sputnik 5 vaccine developed by the Gamaleya Institute, and the Epivac Corona was developed by the Vector Institute in Siberia. Gamaleya Institute in Moscow and Vector Institute in Siberia. These they were not properly tested. Phase 3 trials were hardly conducted. But coming to the Sputnik vaccine, now they are planning to test phase 3 trials in India also. May be effective, but the WHO does not recommend because they are not been properly, proper trials were not done for these vaccines. Now vaccines in phase 3 trials are mRNA vaccines, adenovirus vector vaccine, live attenuated vaccines, and kill vaccines. So mRNA vaccines, these are a new technology. Now you don't introduce a virus or a viral subcomponent, you just introduce mRNA. The mRNA will go to your cell. In the cell, it will produce viral proteins, and your body will develop antibodies to these viral proteins. And this is a new technology, and this is very important because once this technology is there, you can develop vaccines much faster for other infections in the future. So again, coming to mRNA, mRNA is introduced. This will go to your cells, and your cells produce the virus proteins to which immunity occurs. Adenovirus vector vaccine, mRNA vaccines, they are being produced by the company Moderna, that is, and by Pfizer and BioNTech. These vaccines, they are in the phase 3 trials, mRNA vaccines. Adenovirus vector vaccine, Sputnik 5 vaccine is adenovirus vector vaccine. Adenovirus vector is non-infective, so you can use it. The problem is the immunity to adenovirus vector. Now, live attenuated vaccines, our own biotech phase 3 or some like Sputnik have already been in the market, and we expect that these vaccines are available by the end of 2020 or early 2020. So some of the problems unique to COVID-19. So how does it compare to other diseases? As compared to H1N1, these are all preliminary data, and I may be excused if I'm wrong. The mortality rate of COVID-19 may not be much higher than that of H1N1. Problem is number of people infected are very large. Suppose the mortality rate of H1N1 and COVID-19 is both is 0.5. So if 1,000 people are infected with H1N1, 500 people are likely to die. Sorry, 5 people are likely to die. If 1,000 people are infected, 5 people are likely to die. Now, when 1,000 people are infected with H1N1, the same time, 1 lakh people are infected. These are some numbers to make you understand. These are not exact numbers. 1 lakh people may be infected with COVID-19 because it is much more highly infectious. And 1 lakh population is in a person's the COVID-19 that's increase. So another thing is number of days a person with COVID-19 pneumonia occupies the ICU is much higher than a person with other types of pneumonia, creating a shortage of ICU beds. Now, in a normal pneumonia, bacterial pneumonia, you expect normally on an average, you expect a patient to be in the ICU for 3 to 4 days. But in the COVID pneumonia, you can see that some of the patients are using ICU beds for up to 20 to 30 days. So that is number of ICU beds become unavailable. ICU beds become unavailable not because the number of patients are more, but the patients occupy the beds for a much longer amount of time. And what happens when there is shortage of ICU beds? People who actually need ICU are treated in the wards, and people who should be admitted, they are kept at home, creating a backlog and a clog in the ICU. So this is one major problem with COVID-19. And some other thing is effect of PP kits. The doctor or the nurse who has to wear PP kits while wearing these patients, and this limits the amount of time they can spend with the patient. So the number of care providers required per day doubles or triples, resulting in sharp shortage. That is, earlier when our hospital was a normal hospital, we used to have 3 shifts of nurses. That is from 2 shifts of 6 hours each and 1 night shift of 12 hours. That is our system. Now we have 6 shifts of 4 hours each. That means you need double the number of nurses for the same care when you are wearing PP kits, because these people, nobody can use the PP kits for a long time. You get suffocated, your vision is fogged, and you feel numb all over, and very difficult to work in PP kits. And the other problem is doctor wearing a PP kit never able to use the stethoscope. His vision is fogged, he cannot see. So the clinical judgment is also takes a hit, and it takes more time to examine a patient. Normally a doctor will see around 20 to 30 patients in the ward properly, or 40 patients. Now, if you want to see COVID patients properly, you can see, say, 10 to 15 patients. So the number of doctors you need to take care of COVID patients, because you are wearing a PP, that also increases. So there is so that causes a shortage of staff. When the problem is the wards do not have bystanders, do not have relatives taking care of them. So what happens is, if you when the patient needs care, like he has to be fed, he has to be bathed. So a number of people you require, number of staff you require in the ward is much higher. That also causes a problem. So these problems like these are unique, like that the ICU numbers, ICU beds, they are occupied, and caregivers, they are using PPs. All these are problems unique and very difficult in this COVID-19 infection. Now I thank you all for having listened to this talk, and once again thank the Department of Microbiology, Biotechnology and Biochemistry at MA College for having given me this opportunity. Thank you.
Thank you, sir. Thank you, sir, for the interesting and informative session. Let us move on to the question and answer session. Participants, Participants, please write your question in the message box. So can we go to the question and answer session?
Yeah, yes.
Okay, so first question.
Can you please do it fast because I have a duty coming up.
One question is, does RT-PCR give a positive response for a long duration?
RT-PCR, yes. Sometimes it gives a wrong result also because sometimes what happens is there are dead cells which are in the lung, and this gets cuffed up and the RT-PCR picks those up. So even if patients who are not infected, you can see the RT-PCR is positive for 40 days, 50 days. Although the patient is not having the infection, these are all dead cells. So sometimes we have seen that RT-PCR is positive for even up to 40, 50 days.
Okay, sir. Next question. What are Indian COVID-19 vaccines? In what stage they are in testing?
Now, Covaxin, that is vaccine developed by Bharat Biotech, that is in the third stage of testing. So other vaccines, they are, I think, we are doing it in collaboration with some other organization. That is the Serum Institute is doing a vaccine in collaboration with Oxford. This is also in the stage 3 of testing. Other vaccines are also there in collaboration. I am not very sure of those.
Okay, sir. Is it true that antigen test may give wrong result?
Yes, antigen tests are not extremely reliable. The specificity and sensitivity both are low. Specificity is good, sorry. Specificity is okay, but sensitivity is poor.
Ayurveda and Unani has come out with immunity boosters. Are they helpful in reducing the impact of COVID-19?
So I am not the right person to talk about it. I'm not aware of such what is happening in Ayurveda and in any space. So I think I'm not the right person to talk about.
Okay, so 2 more questions, sir. One is, what medicines were given to President Trump which cured him of COVID-19 within a week in USA?
Now, 95% of the people are cured without any drugs. They don't need any drugs. Most of them are asymptomatic also. So we are not sure that what drugs cured him. It may be just be natural process, but we do know for sure that he was given remdesivir and this monoclonal antibody against the virus.
Last question. How does weather affect the coronavirus?
Weather.
Okay.
Now, mortality may be higher in cold weather. That's why now they are having a recurrence of the coronavirus in the Western Hemisphere. And even in India, there is fear in North India that once winter sets in, and there will be a resurgence of coronavirus. And mortality may also be higher. Even here, what you see in Kerala is deaths due to respiratory infections. These are most common in the colder months. This colder month is here. The coldest month is probably June, July, August, where we have monsoons. So here also we see that respiratory infections that are highest in June, July. I'm not talking about COVID-19 alone. I'm talking about all respiratory infections.
Yes, sir. Okay, so questions have been finished. So thank you very much, sir. I invite Dr. Naomi John, Assistant Professor, Department of Microbiology, for the vote of thanks.
Honorable Speaker, distinguished guests and dear delegates, a warm good morning to all of you. Today is a very auspicious day for us, for we have a national webinar on treatment and complications of COVID-19 organized by the Department of Microbiology in association with Departments of Biochemistry, Biotechnology, Marathanesius College, Kodamangalam. I'm here with very much privilege and honor to propose the vote of thanks on the occasion of this national webinar. On behalf of Marathanesius College and the Department of Microbiology, I take immense pleasure in extending my heartfelt gratitude on the successful completion of the national webinar. First and foremost, I thankfully remember the God Almighty for the blessings throughout the program and for helping to complete this event successfully. I extend our sincere gratitude to the most respected Secretary of Marathanesius College Association, Dr. Vinny Verghese, sir, for his constant support and guidance. Thank you, sir. On behalf of Marathanesius College and the Department of Microbiology, I extend our immense gratitude to our honorable resource person, Dr. Joe Joseph, Associate Professor, Department of Medicine, Government Medical College, Ernakulam, for having accepted our invitation and sparing your valuable time, immense knowledge and experience with all of us. Thank you very much, sir, for provoking our thoughts on a topic, treatment and complications of COVID-19. Once again, thank you very much, sir. I would like to extend our sincere gratitude to the respected principal of Marathanesius College, Dr. Shandy A. Avram, for her encouragement and support. Thank you, ma'am. I'm so happy to extend our sincere thanks to Dr. Amnu Yamuna Joseph, Principal Scientist, Primordial Life Sciences, and the former head of the Department of Biotechnology, Marathanesius College, for her valuable contribution and support. Thank you, ma'am. I'm very thankful to all the heads and faculties of various departments of our college for their support and participation. A very special thanks to all the respected participants. I'm very happy to share here we have around 540 delegates for this session, and our participants includes professionals, faculty members from various departments, research scholars, students from various streams, and other interested ones from various countries and across India. We are so grateful to all the participants for your active participation and thereby making this event a grand success. We expect the same support in our future programs. Once again, thank you, dear participants. Let me thank Mr. Ivan Varghese, Mr. Jacob T. Paul, and Mr. Bristow Chaco for providing the technical support to organize this webinar. Thank you, friends. On behalf of Marathanesius College and the Department of Microbiology, I extend our immense gratitude to all of you joined here to make this event a grand success. Thank you all. Thank you very much.
Thank you. Thank you.
Thank you, ma'am. Thus, we have come to the end of the webinar. The feedback form is given in the message box and will be active only for 20 minutes. The certificates will be given within 10 days. And if you have any doubts, please send the message in the group. Thank you all once again. Thank you, sir, for the very informative and interesting talk. Thank you all.